I'm going to get started because we have a very full program. Let me explain the basic shape of things. We're going to do the first hour. We have 3 folks who are speaking. I'll introduce them, and they'll each come up and give a talk about 15 minutes or so for each of the talks, and hopefully we'll have opportunities for people to ask direct questions at the end of each one of those talks. In general, what I'd like to do is give people an opportunity to speak to their slides, give the talk that they're interested in. And in my own experience, if something occurs to you as you're listening to the talk and you'd like to ask a question or sort of emphasize a point, we'll try and make it an opportunity for that to happen immediately at the end of the talk. That way you don't have to sit on your ideas and then try and figure out which person to ask the question to at the end. So we'll try and do that during the first hour, and then during the second hour, we've got a group of 4 people who are going to be giving talks, so they'll be a little bit shorter, but we'll try and follow the same format. So briefly, my name is Paul Kahn. I work as an experience design director at MadPal, and I'd like to introduce the first person who's speaking, Julia Risch. Come on up, and as you set yourself up. Yeah, give me them. Way I can get out of your way. Yeah. Julia is a clinical psychologist and director of design and best practice in the Office of Patient Experience at Cleveland Clinic. She's also the Director of Communication Skills Training and an Assistant Professor of Medicine at the Cleveland Clinic Lerner College of Medicine. She's leading efforts in applying human-centered design to improve patient experience. And today she's going to share the Cleveland Clinic's journey to design a communication training program that would entice the seasoned skeptics. I think that's code for doctors who don't want to talk to you. And improve patients and clinician experience. Julia, please.
Yes. My slides actually are not next. I hope that's okay.
You have the wrong slides here?
It's okay. I can skip to them. It's nice to start with an adventure.
Yeah.
Makes me feel so much more comfortable with my public speaking.
Which ones are yours?
This right here.
This one here.
Awesome, thank you. All right, so this is me. Great, thank you. Thank you for being here. As Paul said, I'm hoping to share a little bit about our journey and designing for our clinicians and their experience at the Cleveland Clinic. So what we designed was a system-wide communication program that we rolled out across our entire organization. And I want to tell you a little bit about that, why we were so intentional in putting this together, why it mattered and what impact it had, and where we are today. So to give you a sense of who's in our room here, how many of you would consider yourself designers? Okay, great. How about clinicians? Oh, great, great. How about purely administrative roles? Okay, or some combination of the above? Great, me too. Fantastic. So thank you for sharing. It's nice to know who you're talking to. So before I tell you our story, I think it's just relevant to talk a little bit about what's happening across the landscape of medicine. I think this is a really compelling picture that you probably saw plastered on the news and internet. But it speaks to the suffering in medicine right now. So about 54% of clinicians are experiencing burnout. If you compare that to the normal sample of people employed, it's about 28%. So there's significant suffering in medicine. And if you think about what is burnout, burnout is essentially cynicism, complete exhaustion, and feeling ineffective in your role. And there's a tremendous impact. So it impacts our patients with the quality, their outcomes, their satisfaction. It impacts providers with higher rates of substance abuse. The impact on their relationships both in and outside of the hospital, as well as some indication that they're retiring earlier. And then naturally there's a huge, tremendous organizational impact of productivity, engagement, and turnover. This is a number of physicians who committed suicide per year. let that sink in for a moment. And about 40% of physicians report experiencing depression. And then about a third, if you could go back in time, wouldn't choose medicine again. And if you think about the very type A personality that medicine attracts, you had a lot of opportunity for choice in that. So you chose to go to medical school, you chose the internship that you chose the residency and the fellowship and the specialty and the subspecialty that you're practicing in. And so to be at a place where you might be regretting all of those decisions, balancing that with a huge responsibility for those decisions that you made at each turn along the way is really quite sad. And there's a lot of reasons. The literature would point to documentation right now as the #1 contributor to burnout. And most recent literature says that physicians are spending about equal time with patients as they are documenting those encounters. So literally, you're moving from the doctor who was a part of your family and community who came to you to the doctor in this picture who has your back to the patient. And where clinicians drive the most meaning from their work is in the actual patient encounter and interaction. So there's something to think about. In addition, like there's just an explosion of technology. So there's 165,000 apps, emails that you are inundated with, thousands and thousands, patient messages. So there's a lot of access and alert fatigue. So there's dings and bells everywhere. Additionally, if you balance documentation and those pressures with the workload that physicians have, as well as the work-life balance challenges, the sleep deprivation, the loss of autonomy and control over your schedule, your work, and the exposure to suffering that they have, the loss, additionally to errors, malpractice. Additionally, there's a changing healthcare landscape, so it's ever changing and uncertain, and there's lots to that. Additionally to the performance metrics, so patient satisfaction, quality, cost. So there's a lot of uncertainty there in what the future will look like. And then the sheer just knowledge explosion. So every 73 days, healthcare knowledge doubles. So to put that in perspective, in 1965, there were 165,000 journal articles in that year. Last year, there were 870,000. So just to stay current is a full-time job for clinicians. So to put you in that driver's seat, I want you to imagine that you are a clinician at the Cleveland Clinic, and you are sitting in the parking lot being asked to go to a communication skills training class. You're sipping on your coffee, you are wrapping up your emails, you're trying to figure out when exactly am I going to fit in this patient that's urgent in the next day, knowing that my schedule is already overbooked. And you're trying to rev up the energy to go to a class that you're not certain that you actually need. So what goes through your head? So please, you don't have to raise your hand, but if you fear this is going to be a waste of my time, or it's not going to be empirically driven, or they're never going to teach me anything I don't already know, I've been doing this for 20 years, or it's going to be too touchy-feely, or do I have to really be here all day? Seriously, I have a busy clinical caseload. And this is what became our challenge in designing training for our physicians, that what would it be, what would it take to compel you to get out of your car and walk into this class? And how could we make that meaningful for you? And so it became a very intentionally designed process. So in the beginning, it was 7 clinicians, not necessarily academic experts, not necessarily curriculum experts, but people that were really in the trenches with you. So people that could really appreciate all the different pressures that you were under, and passionate about, hey, I think there's something to communication that can be really meaningful. And it started out very much like that, a small grassroots initiative. And with some awareness that you were going to be standing in front of your colleagues and your friends who may be struggling with communication challenges, they may be struggling with burnout. We knew at the time that transparency was coming and that our organization was going to embrace that full-heartedly. So it was a very much intentional process in thinking through empathizing with our providers, but also being mindful of what would be meaningful to them. Is this something that would be worthwhile taking them out of clinic to do? And there's a lot of communication models out there. And we actually spent a year looking at what's out there, implementing it, trying it out for us. But what we realized is that there was something kind of missing in that, and that was the clinician's experience. That most models in communication either focus on a very doctor-centered approach or a patient-centered approach, and in both something in someone is missing. And so we started to resonate with this idea of it being a relationship, that we both have an investment in this, and we tend to be more invested in those for which we have a relationship. Additionally, the literature would tell us that relationships can be healing and therapeutic in and of themselves, derive great outcomes as well as satisfaction. And what we notice in our clinicians is that forming relationships is not necessarily intuitive in medicine. So providing great care, diagnoses, treatment planning, all the medical knowledge and expertise was, but not necessarily the ability to connect on a very human and personal level. As well as the appreciation that by doing that, it helps you and your patient. So we started to forge our own path and came up with our own model of healthcare communication called the READY model, which is really built on relationships and establishing, developing, and engaging them over time. This became an 8-hour experiential, learner-centered course, which means the learner is responsible for their own learning. We are not experts disseminating knowledge. We're inviting you to learn with us, and we're also teachable in this process, where you are actually practicing the skills, because we know that adult learners we need to leverage their expertise, we need to engage them in the process, and it needs to be applicable to their work that day for it to be meaningful to them. So everything was built around that knowledge. The other thing is, with the 8 hours, which does seem like a long time, we were very thoughtful about pulling someone out of clinic half of the day, or surgery is a logistical nightmare. So clinic runs late, surgeries run late or start very early. So we wanted to provide an opportunity in space that you could be fully present for that whole time. We're really intentional about the training that we had for our facilitators and how to create safety, a supportive, a learning environment. Everything was empirically driven, and that's important, particularly in our environment. And it needed to be fun and relational. We're thoughtful about who we chose as facilitators. So these were chairmen. We are a surgeon-led organization, so it had to be applicable to surgeons. A variety of specialties. We invited our seasoned skeptics. So the physicians that said to us, this is not going to work, we don't need this, it's not going to be helpful, we invited them up front and early in the process to say, great. So, and rather than meeting that with defensiveness, we said, okay, so what would make this meaningful? What would make this worthwhile for you to come to? Because certainly defensiveness, meeting defensiveness gives you defensiveness. So we're really curious and open to that. Our culture at the clinic is very much physician-led, and so we were intentional in the early phases to speak to that culture and have physicians teaching physicians, because they seem to invalidate sometimes when it wasn't a physician teaching. I'm happy to say that we've evolved in our culture, and we now have advanced care providers, nurses, et cetera, teaching this course and doing a beautiful job of doing that. The other thing that I think we were really intentional about is it's hard to go to a course where your clinic is located. It's very easy to be distracted, or it's easy to run out and go to a meeting and come back, or go see a quick patient and come back. So we were thoughtful to put it across the street in a historic mansion that had a really nice aura to it. So when you walked in and you see the wood floors and the library and the fireplace that's turned on, it gave the impression that this was going to be different. than our typical day. The other thing that you see that's a stark comparison is that if you've been to our hospital, it's very white and bright and sterile and lovely in its own way. So this environment is really different, intentionally different. Speaking to Maslow's hierarchy of needs, we were very thoughtful about all of our communication, prepping people for what to be comfortable, wear comfortable shoes. We're going to ask you to practice with us, but also we're going to feed you and good food with lots of breaks. And every part of that facilitation was very thoughtful. So from the welcome to being very clear about when the breaks would be so that you could check your email, to giving people time to sit down and actually eat a meal, because physicians don't tend to take good care of themselves, as well as creating intimacy. So we had a very small ratio of facilitators to participants of a 6-to-1, so that you could connect with your colleagues and appreciate what they were saying. And what's interesting is, if you go back to that thought about being in healthcare and deciding every step of the way what you wanted to look at. So if I'm in behavioral health and I'm feeling burnt out and I'm questioning, why did I choose this? If I had just chosen derm, I wouldn't have to deal with depression or worrying about the safety of my patients. But when I sit next to someone who is a dermatologist and I realize, wow, they just had to diagnose someone with melanoma. Oh, you know, maybe I am in the right spot. But there's this shared empathy for one another and the challenges that we all have some challenges in these scenarios. At each step along the day, we're very thoughtful how we ask you to interact and exchange information. So from very early on, stepping outside of your clinical role to your very human role, to tell us something about your name, moving up to tell us about when a family member was a patient and what that was like, because it reminds you that it's not your expertise that matters, it's the relationship that matters and how you communicate that. To asking people to talk one-on-one and share what it's like and what stressors they face. The other thing I think we've been very intentional about is keeping things different and fun and experiential. So we've tried different tactics, so from improv, sociodrama, etc. And early on, we actually used to use standardized patients in all of those role play, which we call skills practice very intentionally, because role play has its own, right, visceral reaction. But very intentionally, we opted not to use standardized patients because it wasn't as relatable to my role, but also when I had to sit in the seat of a patient, it made it very real what those words felt like in that role. So I will end in 2 slides, I promise, on 2 things. We're really proud of the work that started out with really the intent to take care of our people and to provide them with a great experience. And in teaching relationship-centered communication, we did provide our providers with a great experience, and that trickled down into other things like patient's experience. And this program has grown exponentially from 1 course to advanced topics to coaching to 73 facilitators teaching this across our enterprise. That's really quite effective. So if we look at the literature, we can show improved patient experience scores, reduced burnout, increased empathy, and regardless of where you started, everyone improves. There was no difference between surgeons and medical physicians, even though surgeons get a bad rap. And what we took away is if we focus on the physician's goals and we allow them to learn what they want to learn, it does affect their experience as well as our patients. And it, most importantly, I think it reminds our people of why they got into this work in the first place, which builds some resilience. So I am so grateful, and I'm so sorry that I went over time. Thank you for that. And if I have a minute, I'll take your questions. If not, you can find me anywhere.
Question from the audience?
Uh-oh. Clear as mud, right?
Hold just a second.
Yeah.
So I just wanted to say I didn't want to start this session by telling you what you were going to hear or what we were trying to prove, and I'm not going to do that right now, but I will just point out that you know, we begin here with a non-technological response to the problem of improving clinician experience. I think we've very carefully tried to have a mix of approaches for the problem, and also You've introduced the 800-pound gorilla at the beginning of your slide presentation, which is documentation. So I think we'll hear a lot about that part of the clinician experience. Thanks very much.
Thank you.
So, Patricia? I think it should be the second one in the one you have there lined up. Yeah, the keynote one. Yeah. So I'd like to introduce Patricia Bjorn. She's creative lead for design innovation at Memorial Sloan Kettering Cancer Center. That's in New York City. In her presentation, Care Within Reach, she'll be sharing how her in-house strategic design group is working across institutional silos to redefine the cancer journey and to expand the contribution of service design to perform both the delivery and the experience in cancer care. Patricia.
Hi, okay, I'm gonna try and get through this very quickly. So I'm Patty Byrne, Creative Lead of Design Innovation Group, which is part of Memorial Sloan Kettering Cancer Center. We're a group of design strategists with the UX design background, service design, design research. We have a behavioral psychologist on our team. So together we leverage behavioral insights, institutional strategy around, both the business of cancer care, the clinical outcomes of cancer care, and the sort of research protocols and sort of our research goals. So all of those kinds of strategies we look at as a team. We research cultural and technological trends, both inside healthcare, but especially outside healthcare, to understand what patients are experiencing in terms of expecting in terms of experience when they walk in the door. And we do a ton of ethnographic research about the patient and clinician experience at Memorial Sloan Kettering, which I will keep referring to as MSK, but I'm going to try not to. But if I do, that's what I'm talking about. And we identify through that research opportunities for innovation that might not be seen when we're looking too close. So our group, the way that we work is very collaborative. We invite clinicians, patients, family members, the food service staff, housekeeping into our innovation lab space to really dig into people's really unique and nuanced insights. We're generative, so we try to work against the inclination in healthcare often to see a problem and to just jump to a solution and get it done. But we try to, as a group, step back and train ourselves and our colleagues to really unpack the problem and reframe the problem and look for adjacencies where we can leverage sort of innovative approaches to getting to solutions. Our work is very narrative. We bring people in, we use storytelling a ton to bring people into the space of understanding how patients and clinicians and others are experiencing care. And we're unique in that we're insiders. So a lot of designers in healthcare, we meet them all day today and tomorrow. There are fewer groups that are actually inside hospitals. There are some, and we're not the only ones by any means, but it's a kind of unique position, and it's good and bad. So it's sort of like we're part of the family, which can be, as any family, there's some dysfunctionality, but also a lot of sort of closeness and familial relationships. So what we're able to ask on a daily basis is, how might we leverage best practices in service and experience design to reach new frontiers in both clinical care and the patient experience? And as insiders, each project that we take on is not isolated, but it builds upon it builds our institutional knowledge around how cancer care is actually experienced from all participants. And so each project we look at as an opportunity for us to know more about cancer care from different perspectives, which is kind of an interesting position to be in. And as insiders in a hospital, I don't know if I didn't get a show of hands who works in a hospital. So, okay. So, as you might know, it's very hard, especially in a really specialized hospital environment, to walk in as a group of designers and be like, don't worry, we've got this. So what we have to do is sell a lot that experience design is a component of care transformation. And we've really gotten there. We're at the table on a lot of projects, which I'll sort of give an overview of. But that was sort of our first point to have to make with our colleagues. But then as designers, sometimes we then get cocky and we're like, we got this. So we have to also keep reminding ourselves that experience design is only one component of transforming care, and that we need all of these other partners in the institution to work with us. So what we've begun to do is look at experience design as playing a unique and integral role in care transformation by being this connective tissue between these different groups, and for different groups to understand and align their objectives towards a shared goal through experience design. And that experience design allows, through iteration and synchronization, allows us to work across these multi-stakeholder groups towards this shared goal. We can't within the hospital stay siloed as many groups do, especially in a very specialized hospital where people are looking at innovation from their perspective and working on their piece. As the design group, we have to not do that. Is that how much I have left or how much I've done? Okay, all right, phew. All right. And so we really have to make sure that, that we're not working in a silo, and if we want to really have an impact on clinical care. So we use co-creation to engage innovation across these silos and make sure that experience design stays sort of at least part of the institutional ethos of how we're going to innovate. So then it comes to defining experience in general. And in a hospital setting, patient experience and patient-centered care is, all the buzz. Everybody's saying it. And at a cancer hospital where, it's a very mission-driven hospital, just about everybody who works there in every role in the hospital, from housekeeping to food service to surgical oncology, everybody is doing it, gets up in the morning feeling like they're going to go make a difference in a patient's life. And so everybody thinks they are an expert in patient experience. But patient experience is often just conflated with patient satisfaction or service with a smile. If we're super nice to the patients, then we've delivered a great experience. So as designers, what we've had to do is really distill down and communicate and socialize that the patient experience and the patient and caregiver experience, we try to always talk about the sort of friends and families, particularly in cancer care, that are supporting the care, is a multi-channeled experience, which means that we have the opportunity to deliver experience through face-to-face human contact with clinicians, frontline staff, and other staff members, through processes, through communications, through digital tools, through objects and environments. Those are all channels of experience, that it's multifaceted. Our patients are experiencing their cancer care not only on a physical level with their disease and the side effects of their treatment, but on a cognitive level, if they understand what's happening and what the word is and how to pronounce the medication they're supposed to take. They're at an emotional level where their stress can impact their clinical outcomes, as can their understanding of what's happening, so whether or not they can adhere to the care plan. Financially, cancer patients are exponentially more likely to file for personal bankruptcy, and personal bankruptcy can be a determinant of their outcomes as well. And they're experiencing their care on a social level. So more than ever before, very advanced cancer patients are still receiving their treatments in an outpatient environment. So people are home more of the time, and they're sicker and at home. But that means that they could potentially be still raising their children, working their jobs, doing what they want to be doing while they're also receiving treatment. And so they're experiencing their treatment in a way that impacts their social existence as well. And the sort of third defining nature of the experience that we've tried to socialize is that it's longitudinal. So to us, in each sort of pocket of the institution, the patient experience is the thing that we see every day. So a surgeon sees the operating room every day or the exam room every day. And so that's the cancer experience that they're impacting. But the patient and their family experiences our care from the moment that they fear that they might have cancer through either survivorship or the end of life. And so that is the cancer journey that they're recognizing. So we need to deliver it recognizing that. And that's mostly what doctors want to do and clinicians in general want to do. And so what I'm about to talk about, this care within reach, is really leveraging the idea of the longitudinal experience, not only as a way of framing how patients are experiencing it, but an opportunity for us to innovate if we think differently about the touch points. So when we ask ourselves how might design support and transform how care is delivered and experienced at MSK, which is Memorial Sloan Kettering Cancer Center in New York City. Can't stay away from the initials of anything. All right, so we look at this, and this part of that timeline, that longitudinal experience, is our bread and butter. Memorial Sloan Kettering delivers on the diagnosis and active treatment of especially rare cancers. And so if we look at what that means in terms of how that plays out, each one of these lines represents an episode of care where a clinician is interacting with one of our patients in one of our facilities, in one of our facilities and delivering treatment. And as Julie so nicely stated, those moments, those episodes are jam-packed with exchanges and information and knowledge. So patients are reporting what their symptoms are, how they're feeling, what their questions are, and doctors are relaying what the care plan is, what the procedures are, trying to get people to understand things. That amount of time, the patients are often spending 4 to 5 times as much time in the waiting room as they are in any of those moments. So that moment holds a lot of weight. And that's another reason why clinicians are super stressed out, because that's a lot to get through. We spoke to one surgeon recently who was talking about an episode of care, which was the first appointment with the surgeon. This patient just found out they had cancer, came to her, and they spent 30 minutes together in their first appointment, 15 of which the patient was crying, wondering if they were going to die. And the surgeon was able to calm them down, then explain the care plan, and it went totally over the patient's head because they were so stressed out wondering about their initial questions. So this this and hundreds of other interviews with clinicians has led us to think about how could we amplify our services to support patients, caregivers, and clinicians in the time before, between, and after these episodes of care. So how can we leverage that longitudinal nature where patients are waiting at home in the waiting rooms, anticipating their care, and create digitally supported services that will amplify our clinical care. So, for instance, how might we better prepare patients and caregivers for their first clinic appointment? How might we set expectations around side effects and coach patients and caregivers to manage them at home? How might we proactively monitor and respond to symptom progression to reduce avoidable inpatient admissions? So how can we use digitally supported services that are just expanding the reach of our clinicians and allowing them to be present in the homes and the lives of our patients, since cancer patients are increasingly ambulatory? And then after we look at that, we've been thinking about how might we extend the reach to engage new populations along the continuum. So even reaching beyond that bread and butter spot from diagnosis through active treatment and looking at the cancer concerned population and how we can use digital services to engage high risk populations around their genetic risk and precision prevention, and how we might transition patients to survivorship and sustain meaningful engagement that does not burden our clinicians' time and efforts and actually delivers real benefit to the patients. So in terms of amplifying, we're rethinking the portal. In terms of diagnosis, we're utilizing remote second opinions test results, patient and caregiver education, and access and preparation for treatment through digital services to prepare our patients so they walk in knowing what to expect. Perhaps they don't have total peace of mind because it is a cancer hospital, but they are coming in at least prepared to discuss. And rethinking in terms of active treatment, how we can provide proactive, personalized and high quality care to keep patients safely and confidently at home. So if our patients feel confident that they can manage their symptoms at home and their caregivers feel like they can help them manage their symptoms at home, then they're less likely to run to the emergency room when something makes them nervous, which happens a lot because people are pretty sick, some of them. And then in terms of extending, for the cancer concerned, we're engaging high-risk communities in genetic testing, counseling, and roadmaps for prevention through digital services, and creating sustained engagement with the survivor community by providing transition and wellness support so that they don't feel like they've been kicked to the curb after we're done treating them. And one day at a workshop, I hope somebody puts designers really care on a post-it, but it hasn't happened yet. Thank you.
Any questions from the...
That was awesome. How big is your team?
We're roughly 10 people. We're 8 designers, a behavioral psychologist, and a strategic initiatives manager.
So you mentioned not being siloed, but you are a centralized team. It's just that you don't embed in the areas, but you're co-creating.
Well, we do have one. We've started a model where one of our service designers is embedded in ambulatory care because that's a huge opportunity for innovation. A lot of our projects are highly ambulatory care focused. So we do have one member of our team that's embedded there and works within that team. But in general, for each of these projects, we embed with a core team that's sort of cross-disciplinary.
And so you have like a set time for that engagement?
Usually it's set time, but because we're an internal team, the deadlines tend to be flex.
Okay, thank you.
So because you have to work across silos, could you give us an example of when you feel like you were successful in bridging that gap and becoming that connective tissue that you referred to?
Yeah, so, and this is like super, like I think we're recently coming of age in terms of breaking down the silos, but we've been able to collaborate more efficiently with clinicians, mostly because we're within strategy and innovation in general. So as the institution at large becomes more innovation focused in terms of service, and not just, in terms of science, it's always been very innovation focused, but in terms of delivering patient experience and service, it's become very innovation focused. So we have clinicians whose time has been dedicated to our projects as well, and that's been a huge move. So if people recognize the innovation projects as something they need to dedicate staff to, that helps. And then as soon as we have clinicians with skin in the game, then it's like a whole new world. But if it's us being like, come on guys, we're pretty sure we could help you with an app, they think it would be a nice to have, but now they see it as essential.
Just curious how you work with clinicians to secure their time to test your concept.
It's really super hard.
Because I work with nurses,
Yeah.
I work with providers, and they're everywhere, but they're unicorns.
Yeah,
And
there's a lot of like having to get our designers to get up and meet with people at 7 in the morning. All clinicians seem to be able to meet you if you meet them at 7 in the morning. So we have to be willing to get up, get dressed, and get to work by 7 in the morning, which is usually against a designer's like natural state. But when it comes to sitting across the table from a surgeon and really talking to them, and then usually they'll put us in touch with their office practice nurse or a physician's assistant and get us in sort of embedded with their team, and usually they'll let us observe in their clinic once we've talked to them. Once we've had the 7 a.m. meeting, they know we're into it, and then we can come in and observe. That's usually where we able to work.
Thank you so much.
Thank you.
Go ahead, Lynn. So I just, as a segue here, I wanted to say that as we were putting this program together, and I talked with Patty on the phone, and I began to understand what she was going to present, it was both exciting and frustrating. It's like, okay, here's a group that's actually thinking out the strategy of where things fit together. Oh, they haven't done it yet. That's too bad. But compared, as I think you heard in some of the other talks, and this may also resonate with some of the talks we're going to have here, having not enough time to think out the strategy, having not enough time to really know where you're going to make a difference, is such a common experience, that to have an organization that has invested in the time to really look at that is really an inspiration. Thank you. So Brad is a co-founder and CEO of Herald Health, an IT startup creating customizable clinical notification platform for clinicians. I'm going to go off script here and just say that how many people here have been involved in health hackathons? Any kind of, oh, great, right? So it was really, this was another one of those wonderful surprises to be able to introduce you to someone who was involved in a health hackathon, won some recognition in the health hackathon, created a company from the health hackathon, and is still running a company after several years that came from a health hackathon. So I think that's really important to understand here. Harold is installed at 2 of the leading academic hospitals in Boston, Brigham and Women's and Boston Children's. Brad is trained as a primary care physician, and prior to Harold, Brad completed an MD, MBA degree between Harvard Business School and Harvard MIT Division of Health Sciences and Technology. That's a lot of little letters, but it's it's hard work, so take it away.
We'll move on. Well, thank you guys so much for the opportunity to speak to you guys today. I'm excited to tell you about Herald Health. So as you got the intro, Herald was actually born out of a hackathon a little less than 2 years ago now, and sort of spent a year in a sort of company state, and now is actually a startup. And we are, as you heard, installed in 2 sites. And the problem that we're trying to solve is the data overload problem for providers in healthcare. So this is a provider-oriented product. So this is just some basic stats on the EHR growth in America. And as we are already all fairly aware, electronic medical records, the use of them has greatly grown. And one of my favorite articles is this 25 quotes that show just how fed up physicians are with EHRs. And so we could go on, and there's a ton of reasons why they are fed up. But there's one particular problem that comes out in a lot of these quotes that I think is relevant. And I really like this description that you have to go wading through hoping you find the relevant piece of information. And it's a totally backwards approach. And the reason for this is that you guys have probably heard this analogy before, but the medical record really serves as a big electronic filing cabinet. And even worse, when new events happen about patients, it's like you have the filing cabinet in your room and somebody sneaks into your office, jams a piece of paper in there, closes the door, and then like runs back out. And then it's your job to sort of shuffle through the filing cabinets from time to time to make sure you didn't miss anything important. And there are some basic systems in the hospitals to try and surface the most important things, but they are actually fail for most of the time. And the amount of errors that happen from missing data or spending a lot of time looking at data that's actually old and doesn't need to be reprocessed is incredible in the hospital. And I think it's summed up in this quote that most systems today are just not designed around clinical care. And so it's this data overload problem that we wanted to solve. So that's why we're creating Herald Health, and our tagline is the data providers need for clinical care. And the framework that we take to this is what we call event-driven medicine. So instead of sort of centering everything around a large patient chart that has everything that you'd ever want for that patient, we surface up the most important events for individual providers to use in order to make it so that they can actually respond to these in timely fashions and not miss the important data that might get lost in that data overload. So what we do is that we actually connect to a lot of different input sources in the hospitals. We connect to imaging data, lab data, vital sign data, admission discharge transfer data, and we suck in all of this data, And then we connect to a variety of output sources that already exist within the hospital. So the hospital where I trained at, the pager is still the dominant modality of communication. Some people have gotten really high tech and use the phone or email, which is a new concept, but and also just embedding within the EMR itself. And so we connect to things that are already within the physician workflow, so that we're not asking them to sort of step away from their current workflow, but actually embed it within workflows that already exist. The way we connect those inputs and outputs is what we call protocols. And so as a protocol you can create, and you say, when the input conditions are these things, for this set of patients, whether or not it's all the patients I'm taking care of or all of my patients with diabetes, whatever sort of subset you might create, I want it to be sent to me via this modality. And you can customize all of these things to your parameters. So maybe a lactate is really important in one setting. You might have different thresholds if you're one type of doctor versus another. And we allow for this to be manually changed based on what might be good for your clinical practice. If any of you guys might be getting this ringing the bell of the tool If This Then That, or IFT. It's amazing in the medical field, especially on the East Coast. Nobody's ever heard of it, although I think in a designer crowd, maybe there'll be a few more. But at a very high level, IFT is a consumer web platform which connects to a lot of input data out in the cloud. So it connects to news data, sports data, weather data, and then it connects to your text message or your email, and then you can make connections that say, if it's going to rain outside today, send me a text at 7 that says, don't forget your umbrella. So at a very high level, what we're creating is IFT for healthcare. And so we do all the back-end integration work and then surface these interfaces for the physician to actually create what we call protocols. In the IFT language, it's recipes, but we're really, we think that they have a good approach for that outside of healthcare space, and we want to bring that to healthcare. This is a busy slide, but this shows one version of our product where you can essentially manage a set of protocols on the left, and then you have an event feed of the most relevant events that are happening about your patient on the right. And the event feed on the right is sort of filtered by the data that you show on the left side and that you sort of use to indicate what is clinically important. You can imagine that creating that is challenging for your average physician, and so the key thing that ties us together is crowdsourcing. So we launch people with a set of protocols, and then we have sort of a long tail of users that are really active on this platform, and then they share their protocols across to other users, and then I can just say, oh, well, you know, Dr. B is a tinkerer. I'm just going to subscribe to his protocols and maybe change them ever so slightly to make for to work within my workflow. This tool can be available for doctors, nurses, NPs, care managers, lots of different groups within the hospital. I'll transition from what the product is to tell a little bit about what we've done, and then I'll save some time for questions at the end. So we were actually very fortunate to get some funding and some recognition from the Health and Human Services, ran a big contest for what they described as a provider user experience challenge, and got first place in that earlier this year, which was part of our, was really based on our results at the Brigham, where we piloted this product and actually launched in August of last year. And we just surveyed our users, had some exciting data from this where we had a net promoter score that is like above 0, which is rare for an electronic tool in the healthcare space. But what we're really excited about is our users who signed up for this actually stayed on, and we're sending tons of notifications in the hospital. People like the tool. It's grown organically, where somebody says, oh, like, how are you getting those notifications? How do you always stay up to date? Let me show you Harold. And so we've been really excited about the growth in that perspective. This is some of the other survey data, keeping people better informed about clinical care. We're hoping that it might let you spend less time in the EMR. We didn't really show that in this, and I think the reason for that is right now everything we do is very much, we're sending you information, but you still have to respond to it within the medical record. Somewhere way down the line, we want to be able to implement things where you can say things like, hey, Harold, I actually want to follow up on this thing that you sent me, and say, now we'll order this follow-up lab. But there's a lot more constraints that prevent that from happening. But and most importantly, people actually think that this is impacting their ability to deliver clinical care. What's that? Yeah, you know, we're going to get it higher. We'll get it there. I think a few quotes that I think really illustrate what we want to do here. It lets people focus on direct patient care. It helps with operational things, like you'll be rounding in the morning and you're seeing patients for 3 hours, and then some lab result comes back on a patient, and you could have discharged them 3 hours, but instead they sort of languish around the hospital. And this is a big deal if you're a hospital administrator trying to get length of stay down and improve throughput in the hospital. And then clinical outcomes, so speed up the time for a patient to get antibiotics in a critical infection situation. We were recently part of this Pulse Accelerator. We're a pretty early startup here, and we're fortunate to get paired up with Boston Children's and Cerner as part of that. And we piloted this in the ED there. The first pilot was in the internal medicine department. But the things that we're really excited about is that we've actually taken this tool, which previously sat outside of the medical record, and it actually sits within the Cerner ecosystem now, and is using their Cerner Code platform, which is their equivalent of roughly an EMR app store. We'll hear from Athena Health later, who has a similar More Disruption Please app store. So our goal is to actually build this in ways that can be expanded at fairly reasonable cost to other systems. The things that I show on the top here are the types of data that we touch now, and that's sort of the basic level that we want to start at. But one of the core issues that we are aware of is that this data overload problem is only getting worse. There's more and more sources of data that providers are expected to keep track of, and we want to actually do the tool that helps integrate from, you know, not just the basic data that's in the EMR, but actually pulling other data in. So home monitoring solutions. You can imagine setting a protocol where it says, if one of my patients' weight has gone up by more than 5 pounds over 7 days, that means their heart failure is worsening, and I need to be notified about this. The biggest challenge from a provider's perspective of all of this home monitoring data that is sort of starting to come about is, what on earth do I do with that? And so if we can actually find ways to actually use tools like this to help providers actually be able to process that data, we think there's a huge value add. I'll close by just mentioning what we actually sell to hospitals. So our product is actually purchased by hospitals, not by the providers. And what we tell them is that we're creating value for them in 3 ways. One is that you actually have a tool that providers like, and the sort of satisfaction of providers hasn't been something that hospital systems have always worried about, but as we heard from the Cleveland Clinic earlier, this issue of burnout is becoming increasingly important for hospitals to solve. Second, we actually help with efficiency. We talked about the throughput in the ED, or getting a patient out on rounds. And then finally, there's increasingly reimbursement based on things like, are you getting antibiotics to the right patient in the right amount of time? And so we actually think that we can really deliver a lot of value. So it's not just a tool that providers want to have, but it's a tool that hospitals want their providers to be using. And we're excited to actually expand this within Brigham. We're actually now growing from the internal medicine department throughout a variety of other departments there, and are looking for other health systems to collaborate with. And so that's all I have. I'd love to open up for questions, and there's my email address. Feel free to reach out. Thanks.
Hi, I am curious about whether there's any recognition of the healthcare team instead of just focusing on a clinician or nurse X.
Yeah, we want to get there. There's a lot of tools in this sort of communication across different provider space, and we're trying to stay focused at the beginning around this specific issue of notifications. But one thing that we're allowing you to do is to use this in pass-off situations. So you can say, well, I need to keep track of this, but actually I'm going to leave the hospital at 5. So this other person is actually going to be the one that's going to be responsible for keeping track of this. So I'll delegate my notifications to the other person on the care team. We haven't quite gotten to the point where we can do integration across, okay, I'm the practitioner and I want to send in alerts to a care coordinator, but you can imagine that's a use case that we want to build out. So you can say, hey, I don't actually need to know about this, A1C that is going up. That means the patient is having worsening diabetes, but I really want my scheduler to know about that so they can bring them in for an earlier appointment. So it's one of the product features we're working on adding, but not there yet.
Right. You touched upon this, but could you cite 1 or 2 examples of larger insights that they can get from the analytics that you might have? I mean, that's tremendous amount of data that you'll collect over time.
Right.
Insights as in the context of population management, even in the with the small population that provider is
Yeah.
managing?
Yeah, it's a great question, and we have the power to do a lot of that analysis because we actually have like every lab data that flows through the hospital actually flows through our system. One of the things that I think people fall down on in healthcare a bit is that when people come into this and it's like, oh, there are all these amazing solutions that I can apply, and I can apply machine learning to this and figure out this new way of getting data. Oftentimes it's something as simple as just like, this lab value exists and I need to know about it. And so we really try to keep things simple at the beginning. And so we're allowing for more sort of multivariate input, so you can have things like, if they sort of trigger this, readmission risk score, we're allowing for that. Although honestly, the things that the physicians want are not as much the complicated analytics and more just, here's the basic data, how do I get access to it? And so we're trying to resist our sort of data geek urge to like dive in there and start doing a lot of analytics on it. I think there's room for that, but it also starts to butt us up against a lot of other population management people, and we want to really stay squarely focused on this issue of how do you actually make a great experience for the individual provider as opposed to thinking about it from a population level. I think there's a lot of tools out there that already do that in other ways. We might be able to piggyback our integration and work with some of those companies, but we don't want to sort of stray too far from the core focus.
I was curious to know about, you said the protocols can be crowdsourced, so is
Yeah.
it like within one hospital system or wider? Like I was thinking about like uses like where it can be actually used for training and
Yeah.
you know.
Yeah, no, we don't have like a formalized system for that. We're at two places, so there's not a whole lot of systems, but it's definitely part of our vision. So one thing that we're excited about with the partnership with Boston Children's is you go to another pediatrics hospital and you say, hey, you can sign up for this product, and not only do you get all these benefits, but you can actually subscribe to the Boston Children's ED protocols, and they are based on best practices that like the top pediatric hospital in the world created. And so that's one of the directions that we're going, but we're not there yet. So.
You have that copyright?
So it's actually an interesting thing. So the hospitals are, as you might imagine, very focused on this, and so we have arranged for sort of like co-selling of the marginal additional benefit of like, here's the product cost, and then if you want to buy the BCH protocols, then we do some revenue share with the system that we come from, which we're really happy with if it incentivizes them to work with us and play into our platform.
So tell me a little bit about how you guys approach evaluation, because you're saying that you crowdsource and people can tweak.
Yeah.
That's great, but we don't know if that's actually the best ultimate outcome for the health outcome.
Sure.
So how do you ensure that you maintain that quality, and I would say take advantage of great ideas from the front line that actually may be an improvement, but you need to empirically verify it?
Yeah, it's a question we get from a lot of hospital administrators, because from a hospital administrator perspective, they're like, oh, like I don't want, 10 different things happening or, 100 different things with 100 different physicians. I think our like philosophic approach to this is that like the top-down approach to clinical decision support and alerting just like really has not worked. When you say, okay, here is like, I'm going to push this out to everybody, and then you use it, and then people just start dismiss, I don't want to pay attention to that. And that this idea that you can give ownership of like how you access the data to the individual user is so powerful that it actually makes people engage with this. So the sell that we try and say to a hospital administrator is like, do you want to give them alerts that you can control that nobody will pay attention to? Or do you want to give them the ability to actually create alerts that like your very competent clinicians can actually use to work within their own workflow that they'll actually use and will actually help them get to better outcomes? And then we can actually, on the backside, one thing we're doing at Brigham is we're actually looking at the actual data records retrospectively, so we can say things like, hey, providers think this helps them, and in fact, when we look at their ordering behavior, they do X, Y, and Z better, which you know that you want that hard outcome, and so maybe you have a little bit less control of it than you'll have in one of these top-down approaches, but we can deliver a better outcome via this approach, if that makes sense.
Partly. So I don't want to monopolize, but let me push back just a little bit.
Please.
So one of the big problems is been variation in care pathways.
Yeah.
And it has actually led to decreased health outcomes.
Right.
I 100% agree with you on the engagement
Right.
and the ability to own a process and customize it. But there needs to be sort of a solving of the issue that they're operating in a universe of best practices.
Yep.
And just because an individual provider thinks, oh, I want this combination of 3 variables, but it's disconnected and maybe even moving away from an optimal health outcome, I would say as a physician, a healthcare administrator, and a data geek, that ain't gonna work. That's not our ultimate goal.
Right.
But it's difficult, and your engagement thing is very well made. I think that's really important.
So I think that it's a great point, and I think that the way that I would address that if I was talking to a hospital administrator is that you're actually you can actually get a lot of data out of this. So one of the big things that people do, there's these SCAMPs, which are these like standardized clinical, I forget what the acronym stands for, but it's basically standardized pathways. And one of the key parts of it is like, you can deviate from the pathway, but just tell us why you deviate at it so that we can all like sort of look at the data and figure out, okay, well, why are all our clinicians deviating? Maybe we need to change our pathway. You can imagine if you're a hospital administrator and you say, everybody's changing their protocols around X, Y, and Z, let's look at that. Like maybe our care pathway's off, or maybe we need to go back, or maybe our pathway is right. We need to go back and do better education with the physician. So you have that ability to sort of like look at the, gather data with this platform, see what people are actually using, and then respond to it with the individual people. So, yeah. Like we're already over time, so I don't want to run.
We're a little over time on this one.
Well, thank you guys so much. It was great to meet everybody.
I also want to emphasize the fact that Healthcare Refactored is a small and intimate conference, and we're all here today, and many of us will be here tomorrow. So I hope people will have an opportunity to continue the discussion based on the presentations. We get our presentations together. Alex, you want to come up? So for our second hour, I feel like we should have a commercial break now, and then brought to you by. For our second hour, we're going to have, I'll just run down the list so you have an idea of who's going to be here. Alex Tam from Augmetics is going to start, JC Galagos from Care Cloud, Jennifer Cardello from Athena Health, and then Roy Smythe from Philips Healthcare. And so we're going to go, as we've started here, with a product that addresses some of the issues that were brought up in a more general sense from the first couple. We're going to start going into both, how do you learn to live with documentation, and how do you improve the documentation systems, and then how do you address some of these larger issues for improving clinicians' experience. So Alex is responsible for leading the Augmetics design organization, driving user experience design across their product platform. Prior to Augmetics, he worked at Practice Fusion and Frog Design, where he led design teams and designed medical devices, wellness applications, and healthcare platforms. He holds design patents in healthcare information technology and has published in journals and books. Alex.
Thank you. You'll have to bear with me. I got off a plane this morning from San Francisco. I'm moderating my caffeine levels appropriately. Speaking of San Francisco, this is going to be a little bit of a Silicon Valley story. Have you guys seen the HBO Silicon Valley series? Looks like a caricature. It's scary how true it is in there. So I think Julie and Brad made the point about EHRs very, very well. So I don't need to dig too much into that, except for bringing up sort of like what it's like to be a doctor within EHR. So a lot of the doctors today, after the clinic doors close, they'll stay back 2 hours to finish their charts, right? Or they'll come in half a day on the weekend. A lot of my friends that are doctors, they see maybe 20 patients a day. So the first half of the day, they'll just see a bunch of patients. They'll be moving from room to room, and they'll like take little like chicken scratch notes on the side of pieces of paper. And then at lunch, they'll try and put down 10 patients worth of data in all at once. So imagine the cognitive load that's happening there. And keep in mind that also that they're trying to do this cognitive task while talking to the patient, a lot of them. So we all know that this is a terrible experience. Thing on the right, also a terrible experience for the designers in the room. So when you think about how clinicians spend their time today, and this, like, there's a lot of variation, but this is a fairly a simplified model that's accurate for a lot of doctors. So third of their time on EHR, third of their time on administrative stuff, and the thing that they went to school for, they only spend about a third of their time doing every day. What if you could do this? right? What if you could take that EHR time and bring it down? One of the anecdotes that I have is, when I was at Practice Fusion, so I used to lead the design team for Practice Fusion. Practice Fusion is a pretty large ambulatory EHR. We had 20 designers, and we're like, we can add a lot of UX and simplify a lot of things, and we can actually make the doctor's experience better. As it turns out, we could probably only make it about 20% better, right, with all of that design horsepower. Augmetics is a different approach, a completely different approach. So if you think about how a doctor and patient engagement works in a visit, a lot of times the doctor is facing away from the patient and their eyes are at a computer. With our solution, it looks like this. Right? You can keep an eye contact with the doctor. He's wearing this funny little thing on his face, but he's got his full attention on you. Right? And how does that work? So we use Google Glass. We put it on the doctor. He wears it 10 hours a day. Some of our doctors are machines. They don't stop. And they can carry a conversation with the patient. On the other end of Google Glass, that video stream goes to another person in San Francisco or wherever else in the world, and that person has two screens. One screen is our interface, and the other screen is that doctor's EHR. So we're taking a human assistant and basically offloading all of that EHR documentation burden off of that doctor. Right? So for the designers in the room, this is what the two parts of our platform look like. The doctor sees messages that we send him in this heads-up display. He talks all day long with his assistant. The assistant types all day long to the doctor, so they have this sort of symbiotic brain relationship all day long. Our assistant has an elaborate interface that we build for them, we design for them, that makes their job a lot easier. I'll just tee up this little video. It's one of our customers put it together. It'll give you a sense of what's actually going on.
The most rewarding part of being a primary care physician is the relationship that we have with our patients.
It was love at first sight. First we hugged. Very unprofessional, but I love it.
There was a time when I was not doing so well. She called me to check up on me. We'll get through this. It really touched me. Yes, can you pull up the healthcare maintenance for my family? I was having an overdue for a common blood test. The class allows us to stay in the moment. She kind of feel a little nauseous. It clicked with me when she wasn't sitting at the computer all the time. She was really able to look me in the eye. That made it a lot easier for us to interact. It's a service called Augmetics. If we need information, it's brought to us. We don't need to go to the computer to get it. Max, could you pull up what I said about the thyroid module from last year? Yeah, so it's completely unchanged. It's hard for patients to remember everything that we told them to do. As things are being said, notes are being created live in real time. After visit summary, here are your vitals from today. In the past, almost a third of my day was spent with my computer. Now I spend maybe 1 to 2 minutes per patient.
So she has the Google Glass. She is not as much closely non-stressed. And I think it's always going to be Santa again.
Glass gives us a little bit more time to interact and get to know our patients.
Take a look.
That's what makes the job really fun.
So how about some data? We ran a bunch of time studies. As it turns out, that chart I showed is fairly accurate. A lot of our doctors for a particular health system, we saw the doctors using about 17 hours a week in charting. Now, in our service, the doctor is still responsible for an accurate chart. They just don't have to do the data entry. So the doctors are still, the clinicians are still signing off on all the charts, but it takes it from 17 hours a week down to 2 hours a week, right? So we're able to save people 2 to 3 hours a day. Can you imagine what you guys would do with 2 to 3 hours a day extra? As a growing company, we're about 5 years old now. We have a pretty good adoption record. my advice for people starting and building companies and trying to engage with the health system is basically follow the pain, right? Charting is one of the most painful things in the healthcare system today. And because we're offering to a health system, we can alleviate some of that burden. They want to work with us, and we have proof points. So what's interesting is that our first generation products are well on their way. We've proven that it works. But while we're providing our service, a lot of the times the clinicians are asking our scribes, our assistants to do even more. And that's led us to think about, what else we can do. So we haven't done this yet, but this is what it could look like, right? So what if you took all of the other administrative tasks and built in protocols, built in machine learning, built in the use of our assistants to sort of coordinate all of that, and you took that admin time down also to 4% of the day. Can you imagine what kind of doctors you could create? This superhuman doctor is something that we joke about sometimes, but it's not just about alleviating the actual burden of the things that they're lower skill things that they don't want to deal with, but it's like we can deliver just-in-time information that allows them to make better decisions. So we've started exploring a number of other offshoot products because our doctors ask our scribes to do it anyways. So one approach is, we call it Care Assist. So because our scribes spend 8 to 10 hours a day with a doctor, each one is trained individually to a doctor, so they know their patterns. They also play this game where it's like, I bet you the doctor's going to prescribe this treatment. And usually they're right because they've spent so much time with them. When there's a protocol that we want to get the doctor to adhere to, if you go to an EHR system, you go to a patient and you fire it up and there's like 9 alerts, the doctors, most of them just ignore it. We already know which one the doctor's already going to do, so we don't fire those alerts. We fire the ones that he's not going to do. And so we alleviate that noise, that signal burden to the doctor because of our relationship with the doctor. And because of that, we're starting to look at a lot of other services that people are asking for. So you've all seen this patient journey, a patient journey. This is one that we put together as a sort of thought experiment around what would be the ideal journey for a patient. This is a chronic patient, so they schedule something, and then something in the system notices that, hey, they're missing some labs, and it would be a much more valuable conversation with the doctor if they had an A1C test before. The doctor does a lot of things around referral and education, documentation, of course we do. They go to what if they don't pick up their labs? What if they don't pick up their meds? Can we check that in the HR and signal the patient? What if there's an adjustment that needs to be made to the meds? Do they have to go to the doctor? Not really. Like, we can send them protocolized questionnaires or forms that routes them to a nurse instead of a doctor. And then, how do we actually make sure that they're managing well and extending the visits instead of like, you should come back in 3 months. Maybe they're fine, that they come back in 9 months instead. So it's less burden on the system and better patient experience. So when you think about what our health system doctors want to focus on, it's really just those two things, right? Provide best care, provide most appropriate care. And if you think about what it takes to deliver that best experience, there's all these other things that have to happen, right? So how do we take all of that, create a much better patient experience, but allow the clinicians to focus on what they care about most? Thank you.
I'm just curious about the economics behind having a second person document the notes live while the doctor is in the interaction with the patient. Obviously, the salary of that second person would be less, but that still seems like doubling your manpower. So I'm just curious how that works and if there's been pushback against that, and if you can talk a little bit about the economics there.
Sure. I mean, our studies show that if you see 1.7 more patients per day, then you've paid for the service. Think about it. So we're saving people 2 hours a day, 3 hours a day. For a clinician that bills out $1 million a year, the economics work really well.
So what if a clinician asks you, why should I use this product instead of an in-person scribe? Are you even trying to market this product to those kinds of physicians?
It's a good question. We get that all the time. There are certain advantages to our system. And because there are in-person scribes, the economics work for that too. So a couple of things that we address for that. One is that we don't take up space in a room. There's a lot of, like, those clinic rooms are fairly tiny, and if there's a person in there, it changes the dynamic of the doctor. A really important thing about having a heads-up display is that we can be very discreet about the messages. A lot of the times doctors, because they're trying to manage so many different things, they forget things, they make mistakes. Our scribe will say, like, hey, doctor, you mentioned you were going to do that, but you haven't done anything yet, or you haven't talked to the patient about that yet. We can be very discreet about that. A live scribe would have a much harder time saying, hey, doctor, you made a mistake in front of the patient, whereas we can. And the other thing is that our video stream can go to multiple people. So we can do a high level of quality control on the scribe. Like if you have an in-person scribe, it's really hard for you to make sure your quality levels are measured.
You have one more quick?
I had a question around, like, so if there's like a procedure or something and there has to be a code associated with whatever's being done, is there like any protocol for that? What if is there room for error? That's one part of my question. The other part is like, what if there's like, you know, I don't know, deeper investigation, like you have to do, like, you know, take your clothes off and whatever. So what happens in that situation?
Yeah, so I'll address the first one, the last one first. Because there's a constant dialogue between doctor and patient, a doctor would just simply say, please turn off the video, and then our scribe has a remote control over that video feed. And then the doctor can do a physical exam, and that preserves their privacy. On the second question around coding, I mean, we generate a much more complete, much more accurate note, which makes it a lot easier for the coders to do their job. We have explored partnerships with coding partnerships, but at the end of the day, you know, in terms of accuracy, it is the doctor that has to sign off on that chart. So if there's an error, there's an accountability based on the expertise of the doctor.
I'm going to hold off on the other questions so we can make sure we get everybody in. Thank you very much, Alex. So JC Gallegos is a product manager at Cloud Care. He's dedicated. I'm sorry. That's never happened before, has it? Right?
No
one's ever made that mistake.
Yeah, thanks.
At CareCloud, who's dedicated to solving challenges healthcare providers face from a software perspective, while ensuring that the development of clinical products is aligned with the industry's evolving needs. So,
Perfect. Thank you. And thanks again for everyone for your time today. So again, just a brief introduction of myself. I'm a registered nurse. I worked in our public hospital in Miami for about 3.5 years. It was an amazing experience working directly with the patients here in the ICU setting. And then I transitioned into a product manager role within CareCloud. And as most product managers do, they kind of fall into that role and then they try to figure out exactly what they do. So this Venn diagram here actually illustrates what it is that we do. So at an intersection between, you know, the business and the strategy and making sure that the products we're delivering achieve market fit and are in alignment with, you know, the strategy of the company itself, ensuring that we're meeting the needs of our users and making sure that the user experience itself is up to par with the specific workflow for clinicians. And then finally, excuse me, working with our development team, which by show of hands, who here is a developer? Because I know we asked about designers and doctors. No, one. Okay, so so working really closely with, you know, the various aspects of the different teams within CareCloud.
The developers are in another
session.
They are here though.
Yeah. And so my role specifically is to making sure that, you know, we're addressing the needs of the client specifically, and making sure that, again, they're aligned with like the business aspect of the company itself, and utilizing the technology platform that we have at CareCloud. And so a lot of times when I worked at the hospital, you know, I got this very similar, or this quote kind of resonated a lot with me based on what I saw there. It was like, you know, the system that's being utilized wasn't necessarily built for us. And so this quote that I found here really resonated with that, and that just because you build something doesn't necessarily mean it's going to get utilized. And it's, you know, basically what is being discussed, and everyone's pretty much in their discussion today, and how they're being forced to utilize all these different types of applications because of all these regulatory requirements that are being essentially kind of shoved down their throats. And for anyone who's worked with doctors or with the clinician themselves, you know how much they love being told how to treat patients and how to take care of the patients in order to get reimbursed for that. So I really wanted to focus today on when we're designing our products and making sure that we're designing for not just the end user, but the clinical end user, and making sure that we really understand their workflow and providing a solution that is embedded seamlessly into that workflow specifically. So again, as we mentioned, this transition from value-based reimbursement to a value-based reimbursement model is forcing them again to utilize all these different forms of electronic systems. So with meaningful use, PPRS, now MIPS and macro, like this is something else that there's just being, again, another burden that they have to kind of deal with. A second thing that was also mentioned too was this increasing patient engagement. There's a huge shift now in making sure that patients are more engaged with their care, which I personally as a nurse love that idea that the patient actually has more control of that. So many times the patient comes to the hospital and they're just, I'm on some sort of medication, I don't really know who my doctor is, so giving them the ability to provide them with tools so they can access information and present it to the clinician when readily available makes it that much more different. But all these things are driving to increasing the provider burnout rate, and so we want to make sure that the technology that we're utilizing and building the products is in alignment with what they actually need. So we actually conducted a survey at CareCloud where we surveyed over 2,000 users of our system, practice administrators and providers as well, where we saw, we asked them, like, what are the top 3 reasons why you would adopt innovations and technology into your healthcare system? And so one of them was, again, to be more efficient and productive. The second answer there was to provide a higher quality of care for the patients. And then third was to increase the overall patient experience. So again, they understand that the technology and the products that we can deliver can actually facilitate a lot of their workflows. It's just not necessarily presented to them in a way that they would want to incorporate into their practice specifically. And so what we've done, and again, we've partnered up with a lot of the providers in making sure that we're delivering the product that they actually need. So rather than presenting them, hey, end user, here is the system that we think that you should use, we incorporate them into the development process. So a client that in ophthalmology, for example, we worked with various groups throughout the country, and we made sure that we involved them in the development process itself. And so we iterated the solution that were offered to them, excuse me, and made sure that we're addressing the actual needs that they needed to accomplish. And we're doing the same thing with the other specialty as well, with rheumatology, podiatry, orthopedics. So we're making sure that the partnerships with these clients, they are really engaged with working with us and making sure that the products we're utilizing are going to meet their needs specifically. And so this was just mentioned that right now, where when we're designing the products, one of the things that we did was that we wanted to serve up the relevant information when it's needed. So again, rather than making the provider go through and dig around all this information that's accessible within that EHR, we provided our solution so that within that workflow specifically, they can have that information available to them. And in doing so, you're also minimizing the barriers to the patient engagement and the communication that's often missed. So if you're, as a clinician, you're behind that computer, you're missing the verbal cues or the nonverbal cues that the patient's offering to you. So we want to make sure as we're designing for that end user that we're taking this into consideration. And so I wanted to leave users with 3 things to think about as we're designing for the clinical end user. One thing is that when you're working on your solutions, to making sure that you're not actually introducing more problems with it. So rather than going through a series of checklists and making sure that the meaningful use requires that you do X, Y, Z, don't make the provider do X, Y, Z if it doesn't align with specifically within their workflow. Try to think of innovative ways to make sure that excuse me, innovative ways to make sure that we're addressing those requirements in a way that aligns with the actual workflow itself. Second thing is to be an advocate for your users. As a nurse, I was an advocate for my patients. I made sure that everything I did was in the best interest of that patient. So it's really easy to lose sight of that when you're designing these products and not necessarily really integrating yourself with the actual end user or the clinical end user. So you need to, I really want to stress having to empathize and understanding the struggles and the pains that they're facing with. So all these requirements that they're being forced to do now, and it's increasing the burnout rate for their clinicians. So it's really important to remain empathetic for that. And the third thing is to close the gap. So with that survey that we conducted at CareCloud, there was a high number of practices that wanted to actually adopt these new innovations and technology within their practices. However, the actual adoption rate isn't as high. So I think that if we were to design a product where, and outside of EHRs, and generally speaking, when we're providing these solutions for any clinician, like we want to make sure that when we're designing these products, it aligns with the actual needs so they can actually want to adopt it. And that's it. Thank you.
Questions out there? So let me just ask. So the product that you're describing here is it's an EHR specifically for practices rather than for hospitals. Is that
right? So we serve more in the ambulatory setting, not necessarily
setting.
inpatient yet.
And do you think that there's any specific features that an ambulatory EHR really needs different from some of the large, an EHR that's being used in a large metropolitan hospital?
Yeah, absolutely. So there's some tools that we're using, for example, rheumatology clients. They are really visually based. So we're actually providing these tools so they can actually document their assessment with their, the joint count and all the different conditions with that. So rather than having to dictate this for its, free text and you want to move away from that, it's just a tool that allows them to quickly document that information in a way that, they almost have fun playing around with this. It's a diagram that all other clinicians that are utilizing for this, they really enjoy using. So thinking of ways that you can document their notes in a way that it's not necessarily forcing them to be behind a computer and doing this and taking away from that patient experience, I think is key.
Yeah, important. Okay, thank you.
Thank you.
Jen? So Jen Cardello is the head of design platforms at Athena Health. She leads teams focused on experience measurement and insights, design systems, and design ops. And her group's charter is to stop. It's the time police. Excuse me. The group's charter is to empower the entire organization to innovate, design, and build great experiences. And I'll let Jen explain what she's going to be talking about today, which I think really dovetails very well with many of the other things that we've been talking about.
Yeah, so we're going to talk about systems thinking and platform today, which is a new adventure for our experience design group at Athena. So I wanted to illustrate this, but there's clearly not enough circles here. So we have about, at last count, 276 Scrum teams at Athena. There's a lot of them. So they're in Watertown, Austin, several sites in India. So there's a lot of product development going on. And those purple dots represent our Scrum teams. And these little diamonds represent the 90 experienced designers that we have. So 276 Scrum teams, 90 experienced designers, clearly not enough experienced designers to embed on every team, but there are 60 Scrum teams that are doing really critical user-centered, user-focused or facing work, and largely it is work for clinicians where it is vital that we have experienced design embedded on those Scrum teams. The Scrum team is typically a product owner, several developers, anywhere from 3 to 5 developers, a Scrum master, and a designer, and sometimes a data scientist as well. And so what we did at the beginning of this year, we used to fully be decentralized and embedded in product. And what was happening is, so you've got 60 designers out on different Scrum teams, scattered all about, designing things for clinicians or for revenue cycle or for whatever. And you find that they are sometimes duplicating the work of each other because there's really just not enough ways to stay in touch. No matter how many Slack accounts you have and email and whatnot, it becomes fairly frustrating. So this is a story of what we're doing with design platforms and the system that we're building, and then the way we're thinking about it for the future. So in platforms, what we did, we pulled a third of our people back, we centralized them, and they focus on 4 things. Design operations, which is really what we need in order for designers to be successful at Athena. So education, onboarding, communications, measurement and insights, which is essentially a rebranding of user research. So we have divided that team into qual and quant, and they are applying that knowledge into evaluating the user experiences that we provide, but also providing frameworks and methods so Scrum teams can also evaluate the experiences they're providing. Global experiences, which is all the things, the connective tissue, the orphan pages and workflows that no one looks after anymore, that become dumping grounds. So we have a Scrum team that's focused on that. They're heavily design focused, so that Scrum team's a little bit more balanced toward the experience design. And then design systems, which is responsible for building the principles and guidelines and UI elements and components that all these teams, the teams that live those triangles will use, or those diamonds will use on the Scrum teams. So our job isn't to be a shared service. We don't go out and look for work throughout the organization. Our job is to empower the Scrum teams to actually do great work on their own, so that they can research and they can design and they can build and they can measure with the tools that we provide to them. So we create methods and frameworks, we focus on the design system, we have education that we provide, and the operational infrastructure. And one other thing, I didn't highlight it in yellow, but the design system is a fairly well-known concept. Over the past 5 or so years, there's been a lot of companies releasing those. We're also creating the sister system to that, which is the research system, allowing people to get access to users more easily through user panels and conduct usability research simply without engaging us. More generative and foundational research would require working with us, but there are things that we can give them in the exploratory and evaluative range. So what are we doing with systems? Like I said, we have many, many designers out there designing things. This example is a dosing calculator that we have. That's embedded in clinicals, but we have mobile experiences, we have all sorts of features and functionality. So the design systems team is going out and finding all these patterns, features and functionality, they're inventorying them, and then they're decomposing them into their atomic elements. So they're taking all these pieces and parts and creating a kit of parts that other people can use to create new patterns. So the analogy I like to use is if I gave you a car and said, go create a kitchen from this car, you'd be like, she's crazy. But if I took that car apart into all of its pieces, you'd be like, huh, maybe I can build a refrigerator out of these several pieces, or an oven out of these several pieces. That's what we're trying to do. We're trying to give them that kit of parts down to that atomic level so they can create new patterns, new workflows, new features and functionality for users without reinventing the wheel over and over and over again. When you think about this, like even if a Scrum team spends 2 sprints or a sprint recreating a button that other teams have already done, it's millions and millions of dollars. And it's just so sad because we really want these designers and developers working at the top of their license. You know, same as we want for doctors. I don't want them reinventing UI interface elements that have been created over and over and over again. We want them spending their time on other types of things. Other companies, like I said, have done this and done it successfully. So Target has a design system that's contributed tremendously to their velocity. Adventist Church as well went through a 20-time increase on how many sites they could publish. Westpac Financial Services had a great increase in how many projects they could take on. But it's really not just about velocity, it's also about quality and cohesion. Other big design systems out there, Salesforce Lightning Design, Intuit's Harmony, and Shopify's Polaris. Microsoft Fluent is another one that was just released several weeks ago. So we're seeing a lot of these design systems being used by companies and being published publicly. Design system, what is it actually? So it's really, we have this onion that we talk about. So it's got a core of interactive UI components. So those might be things built in React or in Polymer. So any of those front-end frameworks. And then there's common UI elements that surround that, the HTML and the CSS that's loosely coupled to the front-end technology. And then that's all encompassed in design guidance. Like, how do we think about healthcare design? What are the principles that guide us? How do we think about composing interfaces? And over time, that's going to get more complicated as we start thinking about like different types of interfaces, not just visual interfaces, but one's controlled by voice and touch. So there's many pieces of this guidance that people need so that they can't make mistakes with the parts. If you just give people the parts and you don't give them the framework, they could assemble Frankensteins, and we don't want to use Frankensteins. So as I mentioned, this is how we see this helping with our designers. Instead of spending lots of time doing UI specification, they're spending way more time focused on experience strategy and experience design. How do we make these experiences better? Redesigning a button 50 times isn't the way we make it better. We need to invent beyond that. So our Athena specific goals: increased experience quality, increased velocity, increased cohesion. And we know we're doing this right if teams start to throw away more stuff. That's a measure of how lean you are. Like, if you don't feel that it's so precious that you're going to have to force users to use it because you never want to make it again, or you feel like you put so much time into it, it's that sunk cost fallacy. Well, I spent 3 years making this thing. Someone's going to use it. I want people to say, hey, we tried it. We put it out there. Resonance testing, down the tubes, chuck it. Put it over on the shelf, and let's come back to it some other time, but let's go invent some more stuff. This is just the nerdy engineering edition of what we're doing. So design guidance, the visual design language, we've got the HTML, CSS, we're loosely coupled so that teams who want to use other frameworks can. We know that React is popular right now. Angular might be more popular next week, or Vue, or Polymer. So we don't want to lock ourselves into a framework. So this is really about us unleashing our creative problem solving. So the way we used to work is that we'd build apps, and the latest and greatest app was the one that informed the next app, and then it just moved like that all around. That's decentralized, it's arbitrary, it's fairly unaware. We need something that's centralized and curated and informed. And so one of the really big pieces of the design system is that it's collaborative and community-based, it's open source. But we think that it could be better if it were publicly available, so that the open source aspect of it really crowdsources from a broader pool of designers and developers. So hopefully lowering the barriers of getting into healthcare, because there's so much to learn. Even onboarding our own designers at Athena takes a while before they're truly productive, because understanding MIPS and MACRA and MU and all the acronyms, are these Athena acronyms? Are these healthcare acronyms? I don't know what this means. Why does this work this way? Healthcare IT is kind of its own animal. It's very different when you've come from other industries. So we want to turn this loose. It's called Forge. It's going to be released in beta for us internally this year, and hopefully in 2018, what we'll be able to do is open this up to the broader community, and people can start using these pieces and parts. This is just the exploration that we've been doing so far. And hopefully we'll have some sort of healthcare design system that people can be a part of. And that's also a piece of our platform strategy. This is my last slide, I promise. So the platform includes infrastructure as a service, APIs, analytics, and the design system. And the way this works is there's producers, entrepreneurs, designers, engineers, anyone who wants to improve healthcare can take part in that platform, and it becomes consumed by clinicians and healthcare professionals. So basically everyone gets more from this. So if you want to talk about it, I know I've run out of time, but contact me, please. That's my email address and my Twitter. Thank you.
Questions?
Yes.
You have that slide where it was technical on the right-hand side, right? And a big team of UI engineers, I would assume, right? And there are things that are certainly easily possible in Angular, and there are things certainly not even more easy in React. So do teams push back once you hand them the designs and whoa, this can't do this, can be simplified somehow? Do they stop the trains? And if they do that, what is your kind of fix to that or approach so that doesn't become systemic?
Yeah, so one of the things about design system, so we use Cotter's 8 steps of change management. Is anyone here familiar with that? I highly recommend it. But the whole thing about this is we spent a lot of time up front building these ally programs. So people who are interested in design systems want to be a part of it. We are not trying to build a governance system. We're not forcing people to use this. That's one of the reasons that we're so adamant about it being loosely coupled. If there's a team who wants to work in Polymer, then we will work with them to make that happen. Maybe we can take some of the components, wrap them in Polymer, and then they can contribute more into the system. So we're not forcing this on anyone. We want it to be the easy path. It's the thing you start with because you can get things done much faster. But yeah, we anticipated that that might become a problem. So it was definitely something we thought about. Yes?
So you're talking about building an open source community, what license are you considering?
I don't know yet. Thank you for bringing that up. So yeah, what would it be? Commons?
Well, typically, Statute 2.0 is the most permissive in terms of software. Commons is more literature.
Yeah. Yeah. Thank you. That's a good point.
So we have a 9-person design team. So we would love to have a system like this, but it's a lot of effort to put one together. Can you comment on at what scale is this is the sweet spot for this?
What scale, like what size?
What size of design team or organization?
It's really interesting. Do you ever follow Nathan Curtis? He's like the guru. Him and Brad Frost are the gurus. Brad actually came in and worked with us on this, but Nathan has a nice little diagram about when you should invest in design systems, at what size, and how old your product is. But I think even at 9 people, it makes sense if you want to move faster. But the thing is, you don't want to, it's a build versus buy, right? So there's a lot of things that you can borrow that exist in Bootstrap and in Foundation. You can borrow more of that. So your proportion would be higher borrow and less custom build. And we should talk about it, because, yeah.
Thank you.
Thank you.
So I'm going to bring up Roy Smythe. So finishing off this really enormously rich marathon we've had today, and I want to thank you all for being here and for giving us some questions, and I hope continuing the discussion. After we're done, Roy is the Chief Medical Officer for Healthcare Informatics at Philips, and he'll be presenting how we can design and develop technologies and workflows that support clinicians' objectives and enhance connection and relationships. I know we're all eager to hear what folks from Philips think about these complex problems.
Great, thank you. We're trying to find my slides in the 2,000 slide deck here. But while you're looking at, are you going to have room to draw my stuff up there? Good. That's it. So thanks for having me. I want to talk a little bit today about so all these great tools we're talking about, how do we get clinicians to use them? I think it was mentioned earlier that it's not what you build, it's what is used. And it strikes me that we've been the most, if you think about North American healthcare, it's been the most innovative industry in the history of civilization. You think about the tools we've created, the MRI scanners, the proton beam treatment devices, the things that we put into people's homes at Philips. We've been really innovative at designing stuff. We've been really bad about designing new processes. You know, the process of healthcare hasn't changed in a century. You're a little bit sick, you see one doctor. In a small box, you're a lot sick, you see a lot of doctors in the big box. And it strikes me that we need to pay a little bit more attention to designing processes. And we'll talk a little bit about how do you convince, what's the process of convincing a clinician to use a new tool that could change the delivery process. And it's first, I think, important to remind you that innovation always, always, always requires behavior change. Otherwise, it's not innovation. Because the innovation pathway always adheres to these 4 steps. And this can be done iteratively in a lean startup methodology, but you've always got to go through these 4 steps before you get an innovation. You've got to have an idea. Ideas are wonderful, but they're cheap. You've got to have an invention of some sort. So for a device, this is a prototype, and for a process, this is a pilot. You know, it's got to be made real in the real world. It's then got to be adopted by a sufficient number of individuals so that it creates value for those that are using it or those that might be at the end of the value chain for the use, only then is it an innovation. And so it always requires behavior change. One of my favorite requests when I was a medical school department chair was for one of the health system administrators, which I then became later myself, to tell me that we need you to change your physicians' behaviors. I need you to make your doctors do blank. It's really easy, just do blank. And of course, what that person didn't realize is that in most states, and actually most countries, in order to have a license to practice medicine, you have to be an adult. And I don't know how you feel about this, but in my personal experience, you don't change another adult's behavior unless you imprison them. You convince them that it's a good idea for them to change their own behavior, for them to make their own decision to change their own behavior. Let's talk about some things that, a couple of things that have been discussed frequently in regards to what might change the behavior of clinicians, when using new tools or adopting new practices, and that's money and data. Money and data. Things that don't necessarily work. So, in the 1970s, Oldman and Hackman were a couple of sociologists that studied engineers. And they studied engineers. They wanted to know what motivates engineers to do things, to do their jobs well. And when I read this several years ago, I thought, doctors and engineers are very similar. They tend to be very autonomous. They tend to often identify themselves with their area of specialization more than their employer, and they tend to be difficult to manage. And so I thought, well, let's look into this a little bit. Maybe some of this would apply to physicians too. And what Oldman and Hackman said is that in a cognitive endeavor, and I would suggest to you that practicing medicine is cognitive. And it's not assembly line, although we have tried to create a system that looks a lot like that. That in cognitive work, individuals are ideally motivated by things other than money alone. And what they showed is that these 5 things predict these 6 things. Task identity, the fact that I don't feel like I'm on an assembly line putting a screw into a socket. I actually am working across the assembly to some degree. The next is skill variety, that to do my job, I feel like I'm using a number of skills. And sometimes I'm pushed by that. I have to learn new things. The next is autonomy, that I have the freedom, independence, and discretion to design my work so that I can get the product that you want me to get. The next is feedback. We all know what that is. Now, how am I doing? Objectively, how am I doing? And last is task significance. And when I read this, I thought this really sounds like healthcare. Task significance means that my work product has a positive impact on someone else's life. And what that predicts is motivation, satisfaction, performance, turnover, absenteeism, and compensation rumination. I can tell you when you pay clinicians, don't ask me how I know this after being a medical school department chair for 10 years, but if you pay clinicians for each screw they put into the socket on the assembly line, they come to you asking for more money. Daniel Pink wrote a book called Drive. It distills a lot of social science around motivation and compensation, and he would reiterate that you take the issue of money off the table for cognitive workers, you pay them what they're worth, and when you do this, they'll often focus more on the work product itself. What about data? I think this has already been discussed to some degree, and I'll just reiterate that it's not data that clinicians want, it's insights. And actually, if you can give them recommendations beyond insights, and if you can actually give them operational support to act on those recommendations, even better. They have full-time jobs. Parsing through big data, even if it's been distilled down to something that's slightly more manageable, is not what they want to do or have time to do. What are 3 things that can work? And this is based on my personal experience and also, again, some social science. A lot of this came from a distillation of social science in a book called Influencer. I would suggest you might want to read as well. Transparency, instilling confidence, and appealing to higher order values. Transparency. Be very clear. What's in it for me, the clinician? What sacrifices will I have to make? If you're having trouble articulating the benefit of the new practice or the new product or the new tool, beyond that which has utility for the employer alone, think twice. Think twice. Medicine's an altruistic profession, not a masochistic one, I like to say. And as Gandhi said, the truth never damages a cause, it's just. Instilling confidence. When you hear someone say, I can't do this, what you need to parse out is what are they really saying? Are they saying that I think this is intrinsically a bad idea? Or are they saying that I don't believe I have the competence, support, or tools to do this? And often in healthcare, in my experience, it's the latter. So to instill confidence, make sure that individual knows that this is a new process or a new product or a new tool. It's not going to be easy. This is where the pain's going to be. But these are the things I'm going to do to support you through the process. And then lastly, of course, it's higher order values. And so why should I really do this? Why should I do this? The business ethic is seeped into healthcare delivery, in part for good reason. There's no reason why we shouldn't be good stewards of the money that we spend. However, productivity is not the goal of healthcare. It's not the goal of healthcare. The goal is to relieve suffering and extend meaningful life, to maximize human potential. So if you've been transparent, and if you have instilled the confidence that you can use this new tool or see through this new process, what is the impact going to be on the patients that you take care of? Appeal to higher order values. And I can give you several examples of this if you'd like to catch me afterwards where I've seen this work in practice. And last, just a couple of comments about EHRs. So I think it's interesting to maybe look through this list of things I just mentioned as potentially being useful in the deployment of a new tool or new practice, and let's see how we did with the EHR. So were we transparent? Not really, right? I don't think most clinicians knew how difficult it was going to be to use this new tool. Were we instilling confidence? Well, we did have a couple of hundred individuals live with us for a year from Epic or from Cerner or from whatever company that we were working with. So we tried to do that. Well, what about appealing to higher order values? Clinicians know, and they knew when these EHRs were deployed that these were solutions to capture data and to more effectively bill. They weren't certain that this is going to have a positive impact on their patients' well-being in the short term. Last, just a couple of comments about the technology issue around the productivity paradox. So I've talked about the three things that we might not have done all that well, but what about the technology itself? So there's been a lot of study of something called the productivity paradox. We've seen it twice in the last 150 years. The first was when electric turbines replaced steam engines in factories. If you've ever been in an old factory, you look over on the left-hand side, you see these pulleys and belts that were in the ceilings. And you had a giant steam engine that sat in the middle of the factory that attached to a big pulley with this wheel on it, and attached to a smaller pulley, smaller, and eventually came down at the back of the factory to a sewing machine. This is how factories ran. And we had decades of experience with these giant steam engines. We could regulate the power very effectively. Well, along came these electric turbines, going to revolutionize manufacturing, right? So we said, well, we must use them just like we use the steam engine. So we built these giant turbines with no ability to regulate the power. We sat them in the middle of these factories. They blew up, they broke the belts. Everybody said, this stinks. Productivity sunk. Of course, over time, it got better. The second was when computers were used in office settings. And actually, I can remember when I was a child, my father's little insurance office in Texas, where the secretary got her first computer and said, this thing's terrible. You know, my IBM Selectric is much better at writing letters than this computer is. And so what historians say is that platform technologies only improve productivity when two conditions are met. The first is that you no longer use that technology in the old context. The EHR is still viewed by many, not all, but many, as an electronic paper chart. That's not the context for the EHR. The second is platforms only work when things are placed on them. When the tools that make the platform work are added to the platform, and you've heard some people talk about some of those tools today. So I don't think we should be surprised or necessarily discouraged by what we've seen with this particular example of technology adoption, but I think whenever the next platform comes along, we can probably do it much better. Thank you.
Questions, please? Or observations, those of you who sat through an hour and more of really interesting stuff. Does anyone has any comments they want to make?
Hi, so I'm a medical student, and my one incentive is getting grades that will help me pass medical school. And I'm curious about why a lot of these technologies are not introduced to medical students, why they aren't one of the primary consumer bases that are targeted, why they aren't taught to work with this kind of technology, trained to think about how to use EHRs, trained to think about how to get used to new kinds of technology, because that's going to happen again and again and again, even faster in the next 50 years for us.
Yeah, so it's interesting. This is a time of year when new residents are going to start on July 1st. It's considered by most people around the world to be the most dangerous month to get sick. But it's also the time of year when I think about educating new clinicians. And listen. So first of all, I think just to be transparent myself, there's a lot to learn, right? I mean, and so technology is only a piece of it. It's an important piece. But there's also all the other stuff, right? I mean, all the names of the bones and muscles and nerves and blood vessels and how they work and so forth. And so there's a lot to learn. The other thing I'd like to say is that, listen, I hope that you would have learned today by listening to the other presenters that those that are actively providing care aren't necessarily using technology to its greatest benefit yet. I mean, it's going to happen, right? But this is a risk-averse, perverse payment model, highly sunk costs, billions, trillions of dollars in the old model, and sort of hooked on the old model of making money industry. And so those are four big impediments that have to be overcome. So I would say, the great thing about young doctors and residents is they push the older ones to use new technologies. And so when you see an opportunity, push, but don't forget, you still need to learn the names of those bones, muscles, and arteries and nerves. Yeah.
I want to ask if everyone who spoke today would stand up again, please. We had a really great group of people. Thank you all very much. Again, I'll remind you.